everyone, my name is Priya and I'm a final year medical student in Newcastle University Medicine, Malaysia. And today we are going to talk about chest X-ray interpretation. Medical students are commonly tested or asked in placements and exams to describe chest X-ray, and there are so many ways to describe chest X-rays. Personally, I use the ABCDE approach. So in this video, first I'm going to cover what are the things you need to be writing down in your chest X-ray notes, and then I will guide you on how to use the ABCDE approach, and finally I will take you down through 4 sample cases using the ABCDE approach. I hope by end of this video you will be confident enough to comment on a chest X-ray by your own. Check out in the description below for the timestamp if you want to focus on a particular chest X-ray to save your time. Enjoy!
These are some of the important points you need to take note when you are looking at a chest X-ray. First rule, don't panic and straight away start describing the X-ray. First, look into the patient's details on the side of the film. Is it the correct name? Is it the correct date of birth? Take note of the date and time the chest X-ray was taken. It will be great to mention if there's any previous imaging for comparison as well. And please ensure which side is which in terms of right and left. Next, you want to describe the quality of the image. I like to remember this part as RIPE in terms of rotation, inspiration, projection, and then exposure or penetration. So let's get into rotation first. In terms of rotation, you want to look at the clavicles. If the medial aspect of the clavicles, are they in similar distance from the spinous process? Once that's done, look into the inspiration. You want to calculate the anterior ribs. You are supposed to look at 6 anterior ribs and then 10 posterior ribs. And if you can see all of that clearly with both of the costophrenic angles, then it's a well-inspired film. Then for your projection, you want to know whether this is an AP view or a PA view. Remember that gold standard to view a chest X-ray is normally PA view, because that's how you can identify the heart size correctly. Next, you have the exposure or penetration. If you can see the left hemidiaphragm until the spine and the vertebra is visible behind the heart as well, that's a pretty adequate exposure of X-ray film right there. So, how do you say all of this in one word? So, this is how I normally describe. It's a well-inspired AP film, chest X-ray with adequate exposure and not rotated. So, once you have commented on the quality of the image, now you want to describe the chest X-ray. I personally use ABCDE approach. So, it's airway, breathing, cardiac, diaphragm, and everything else. So, let's get into that. Firstly, it's A, airway. You are going to look at the trachea, the carina, bronchi, and hilum, whether they are deviated or is there any obstructions there or not. Next is breathing, B. So for breathing, you are basically looking into lungs and the pleura of the lung, or also the pulmonary vessels or lung markings, and basically the vascularity of the lung. Next, C, it's cardiac. So you're going to assess the heart size, whether there is a cardiomegaly or is there a dextrocardia, and then you want to assess the cardiac borders, whether you can see every borders clearly or not. Once that's done, it's D, diaphragm. So this is where you will look into both of the hemidiaphragms and the costophrenic angles, and also you want to assess whether there is any air under diaphragm. Yeah. Next, E, everything else. So you want to look into mediastinum, the aortic knuckle, the arch over the left main bronchus, and then not forgetting your bones, your soft tissues, any tubes, pacemakers or surgical clips, or even NG tube. So you want to mention each and every single detail that you are seeing in the chest X-ray. So after all of this done, before you complete your assessment of chest X-ray, you want to just quickly run through the whole chest X-ray and then look for review areas. So these are the areas normally pathology is missed sometimes, like lymphadenopathy or like small nodules. So the places like lung abscess, the behind the diaphragm, your hilar region, and also the peripheral region of your lung. So you are just going to quickly run through all of these places and conclude your chest X-ray findings. First case, 60-year-old man presents with acute shortness of breath with underlying ischemic heart disease. There is dullness to percussion and inspiratory crackles heard in both lower zones of lungs. Let's go through this chest X-ray now. When you are looking into the chest X-ray, look into patient's details, the date and time the chest X-ray was taken. Here we only have that this is the right side of the patient and we have the view. So it's an AP erect chest X-ray view. So let's crack on with the imaging finding. First, it's A, airway. Look into the trachea. So here the trachea is central, but there's a bit of a rotation here. So you can see the medial aspect of your clavicle, and then you have the spinous process here. Can you see the distance on the right side is more than the left side? So probably when the chest X-ray was taken, the patient rotated towards the right side a little, but this is fine. You can exclude things like tension pneumothorax here because the trachea is central. That's what's more important. Next, B, it's breathing. So you're looking into the lungs. The most obvious abnormality that I can see throughout both lungs is some kind of opacity, but it's a very fine line. So this is what we call it as a reticular shadows, or you can call it as a fine linear lining as well. But in a proper term, you can call them as interstitial opacification. This happened due to too much of water being accumulated in your interstitium of the lung. The next thing that you can see that's obvious is the prominent upper lobe veins. They're pretty prominent here. So these are probably happening due to massive pressure coming out from the heart, especially from the left atrium. So that's why they are transmitted towards the upper lobe, and your upper lobe is being dilated so much. That's giving this kind of image in your chest X-ray. So other than that, in breathing, you also want to see the pleural space. The pleural spaces are clear. The lungs are not hyperinflated by actually counting the ribs. That's done. Let's move on to C now. So C is cardiac. So cardiac, you want to measure the cardiothoracic ratio. How do you do that? By placing an imaginary line here. This is your thoracic ratio. So next, check out the cardiac border. So I can clearly see the cardiac borders here, left and right. This will be a cardio, your heart. So if the cardiothoracic ratio is more than 0.5, which means the heart ratio is actually more than half. So here you can clearly see that it's actually more than half, right? So this is can be a cardiomegaly. Why am I saying can be? Because remember, this is an AP view. AP view, normally in AP view, the heart can be enlarged. So if you want to confirm a cardiomegaly, take a PA view and do the cardiothoracic, measure the cardiothoracic line again and confirm that this is a cardiomegaly. Alright. Next, the heart borders are clear, and you can see the mediastinum, they are not deviated and they are in central. The next thing is the hilum here. So the hilum, they are a little bit enlarged. Probably it's due to the accumulation of water, and they are vascular in origin as well, and they are in normal position. There's no like increased density, so you do not have to worry too much about it. So C done. Next we go to D. D is diaphragm. So diaphragm, you are looking at down there here. So you can see this is your hemidiaphragm. I can see a clear hemidiaphragms here. But the costophrenic angle, can you see some abnormalities here? Compared to this region, here it's much blunted. So you can see there are some kind of small pleural effusion here. Too much of water they are being accumulated, probably. But then hemidiaphragms are normal. There is no air under diaphragm, which we call it as pneumoperitoneum. Finally, E, everything else. So you just want to take a quick overview of everything. So the bones are fine. There's no bony lesions. The soft tissues are fine. There's no like sclerotic or lytic lesion. There's no vascular line or pacemaker, tubes or clips like that. This is a feature of heart failure due to cardiomegaly, interstitial opacity, small pleural effusion, and also upper lobe diversion. Second question. A 35-year-old man presents with difficulty breathing associated with productive cough and fever. There is decreased air entry, dull to percussion, and crackles in left lower zone.
Just like the previous imaging, we are going to look at the patient details. So here we have that this is a right side of the patient and it's an erect chest x-ray. Probably this is an AP view. Why do I say that? Because the heart does look a little enlarged, and this normally happens in AP views compared to PA view. Okay, let's use the algorithm again. So for A, the trachea, here the trachea is central and there is no rotation because the clavicles are here, and you have the spinous process. You can see the distance is pretty equidistant between each clavicles, right? So there's no rotation, the trachea is normal. Next is B, breathing. So breathing, let's look at the lungs. The right side of the lung is pretty clear. The lung markings are there. But can you see on the left side, especially at the left lower lobe, you can see some kind of opacification. So this is what we call it as heterogeneous opacification. That means it's a structure with various components like solid, liquid, gas. It's all mixed up. And other than that, the rest of the lungs are clear. It's not hyperinflated. But at the same time, due to the consolidation, you can also see that this is your hemidiaphragm that I'm drawing. This is your hemidiaphragm. The right side is pretty clear, but can you see the left side? It's pretty blunted because of the consolidation. So you can add that in your breathing as well. Next, C is cardiac. So like I said, the heart is a little enlarged. This is due to the view. It's not a cardiomegaly, right? So you want to draw the cardiac border now. So I can see a pretty clear cardiac border. It doesn't look enlarged, it's all because of the view, and the aortas are normal, and the mediastinum is central as well, it's not deviated, so you can add that in your cardiac C. Next is D, which is diaphragm. So since we have drew the hemidiaphragms, let's look at the costophrenic angle as well. The costophrenic angle on the right side is pretty clear, but I really can't see on the left side. So you can see there's a blunted costophrenic angle on the left side. At the same time, the hemidiaphragms are a little obscured on the left side as well, whereas the right side is normal. And there is no pneumoperitoneum like air under diaphragm, right? So finally, it's E. E is everything else. So for everything else, there's no bony lesion. I don't see any fractures here. And the soft tissues are normal, these areas. The soft tissues are pretty normal. And then there's no vascular lines or pacemakers or surgical clips that I can see here.
This X-ray demonstrates a consolidation in left lower zone. The consolidation has obscured the left hemidiaphragm but not the left heart border, and there is small left pleural effusion as well. So this is consistent with left lower lobe pneumonia. Third question. 27-year-old female presents to emergency department with sudden onset right-sided pleuritic chest pain and feeling breathlessness. There is increased hyperresonance in the right side of the lung with reduced air entry. Let's check out her chest X-ray.
So here we have the right side of the patient, and this is an AP chest X-ray view. So for A, airway, the trachea, can you see it's a little deviated toward the left side? But we need to confirm that by looking at the clavicles. This is your spinous process. Can you see the distance of the right side is actually more than the left? So what's happening here? Actually, the patient is rotated towards the right side a little, just like the first case that we looked into. Okay, so because of the rotation of the patient, the trachea looks like it has been deviated, but it's actually a central trachea, right? It's not deviated. Next, we have B, breathing. So you can see an obvious abnormality on the right side. That is your right lung. So can you see the line that I'm drawing here? This is actually your right side lung. What has happened here is so much of accumulation of air has caused
an almost complete collapse of your right lung. So this is what we call it as a large pneumothorax in the pleural cavity. So this has moved, like pushed your right side of your lung and caused a collapse here. And you can see, you compare to the left lung, here you can actually see the left lung markings very clearly. But can you see here on the right side, there's nothing. It's just air. So that's one trick to look for pneumothorax. And the left lung, like I said, it's clear, the lungs are not hyper expanded as well. And the pleural spaces are clear with normal pulmonary vascularity as well. Next is your C. So C, you're looking at the cardiac. So cardiac, I can see a clear left heart border here, but it's quite hard to look at the right side of the heart border. So it's quite hard, probably due to the patient's rotation or just the right side lung collapse. So it can be a little difficult to identify the right heart border, but the left side is clear. The heart is not enlarged, but you can't confirm it with AP. You need to confirm it with a PA view chest X-ray. And the next thing that you want to look for is the hilum. You really can't see any right hilum here because of the right-sided lung collapse. But then the left side is pretty normal, and the position is good. The size and shape of the left hilum is okay, and also the mediastinum might look deviated towards the left side a little, but actually it's not. It's just due to the patient's rotation. So the mediastinum is actually central. It's not deviated, and the borders are clear as well. All right. Okay. Next is D. D is diaphragm. So let's draw the hemidiaphragms here. I can see clear, both clear hemidiaphragms, and the costophrenic angles are clear as well. It's not bad. Both are clearly seen. It's not blunted at all. And then there is no air under diaphragm as well. Then we have E. So the bony lesions or fractures. I don't see any fractures or bony lesions here. There's no surgical clips. There's no vascular lines here. And the soft tissues are pretty good as well. There's no any abnormalities.
So this X-ray demonstrates a large right-sided pneumothorax with almost complete collapse of underlying lung. The apparent mediastinal shift is probably due to the patient's rotation. However, the patient will still be clinically assessed for tension pneumothorax. Final chest X-ray, and it's a little bit harder one. 65-year-old female complains of 12-week history of cough, and she has 25-year smoking history. From examination, lungs are resonant throughout with good bilateral air entry.
Here we only have, this is the right side of the lung, and let's move on with the imaging. So A, airway, the trachea is central. You want to confirm that by drawing the medial aspect of the clavicle and the spinous process. You can see it's similar distance. So you have confirmed that the trachea is central. Next, it's breathing. So you can see a very clear image here. It's actually like well-defined lesions. Am I right? This is what we call it as opacities. It's a well-defined or well-circumscribed round opacities, and this is not heterogeneous, but this is homogeneous, like I said. So just now the second question was about heterogeneous, so this is homogeneous opacity, and they are present throughout both lung as well. And you can see multiple here, so I'm just drawing out some of them, and this is it. So many here, and these are very consistent with pulmonary metastases, so cancer basically. But other than that, the vascularity of the lung is normal, the pleural spaces are clear, and the lungs are not hyperinflated as well. Next is C, which is cardiac. So here you can see a clear right side border, left side border. The heart is not enlarged, and you have clear borders. The mediastinum is central as well, but you want to notice one thing. Here, or let me use a brighter color, the hilum is actually a little bulky. Let me just delete that. Can you see it's a little bulky here, the hilum? So that's one that we can notice here. So both sides is bulky or enlarged hilum, you can see that. Okay, and then D is diaphragm. So you want to draw your diaphragm here. So the diaphragms are pretty clear, and the costophrenic angles are clear as well. They are not blunted. Alright, so that's done, and there's no air under diaphragm, no pneumoperitoneum. And finally it's E. So E, you want to look into everything else. The bones are intact, there's no fractures that I can see, the soft tissues are unremarkable, but then there are some ECG electrodes that you can see here, right? So you want to include them in your imaging list as well. So you're just going to say there are some ECG electrodes. Other than that, there's no vascular lines or surgical clips.
Alright, this X-ray demonstrates multiple rounded pulmonary masses in keeping with the metastasis. The hilar appear bulky. This could be due to the pulmonary metastasis projected over them or related to enlarged hilar lymph nodes. The differential diagnosis for cannonball metastasis includes breast cancer, renal cell carcinoma, choriocarcinoma, and endometrial carcinoma.